Hello, I'm Karim Fizazi from Gustave Institut in Villejuif, France, and I'm happy to welcome you here in San Francisco for the ASCO GU 2014, which is actually the 10th ASCO GU that we have. It's really a great opportunity. So this will be for the e-cancer highlights, and I'm really happy to be joined here by my colleagues, Dr. Cora Sternberg from Rome, Dr. John Fitzpatrick from Ireland, and Dr. Heather Payne from the University of London in the UK, and Dr. Peter Nelson from Seattle University of Washington. So first of all, because the last decade, I guess, has been quite tremendous with lots of great news, and I guess we're celebrating that today here at ASCO GU, I would like to ask you first, what has been the major milestone in your own specialty when it comes to prostate cancer? So Cora, first, in medical oncology, what do you think?
Thank you, Karim. In medical oncology, we have had an incredible time in the last 10 years since we found that docetaxel chemotherapy improved overall survival. And for patients with metastatic castration-resistant prostate cancer, in the last 10 years, we've actually approved 7 new drugs. 7 new drugs that have improved overall survival, and most of these have also improved quality of life in our patients, which is extremely important. We've also approved other drugs which have helped in terms of improving bone health.
All right, excellent. John, the urologist, what is maybe the main milestone in prostate cancer?
Well, I suppose that when you ask me that question, you confidently expect me to say the robot. But I'm not going to say the robot. In fact, the robot has not really changed anything. It's a very nice technique, but it hasn't improved any outcomes. And indeed, I believe, as I think most people do, that what is important is the skill of the surgeon. Actually, the big change that's happened in our practice is the multidisciplinary team meeting. The MDT meeting has changed the whole outlook of urologists to the management of prostate cancer, and it's all for the good.
Staying with multidisciplinary management, Heather, as a radiation oncologist, what has been the most important improvement in the last 10 years?
I think I'd echo the bit about the multidisciplinary team, because it has made an enormous difference. We're all sitting here quite in a friendly manner today. From the radiation point of view, I think it's been locally advanced and high-risk localized disease, and it's the recognition that hormone therapy in combination with radiation treatment has shown big differences in overall survival. And I mean, I think that's been a huge improvement in the way that we've managed these men who before there was a slightly nihilistic approach to them, whereas now we're seeing cures in people with these high-risk features who are treated with combination modality.
Absolutely. Pete, the biology is back. We know much more than we knew 10 years ago, and many of all the new treatments actually came from our knowledge and improved knowledge from the biology. What would be your most important milestone?
So I think it's been an astounding decade, really. I would say the real advances have come from really understanding the molecular biology through new biotechnology, sequencing, for example, that has now defined recurrent molecular changes such as the TMPRSS2 ERG fusion rearrangement that occurs in 50% of all prostate cancers, a better understanding of mutations in the androgen receptor that confers resistance now to some of our newer next generation therapies, an understanding of pathways of hormone biosynthesis through upregulation of synthetic enzymes within prostate cancer cells. So the fundamental aspect is these new technologies allow us to more deeply understand the drivers of within an individual prostate cancer cell through different disease states all the way through to resistance.
All right. So that was the past, and let's now stay with the present. I guess the most important scoop that we had today at ASCO GU was really the release of the PREVAIL data looking at enzalutamide in early CRPC patients Cora, can you summarize this data and tell us what you think about it?
First, let me tell you what enzalutamide is. Based on our increased knowledge of the androgen receptor and the androgen receptor biology, enzalutamide was first developed for patients with metastatic castration-resistant prostate cancer who had failed chemotherapy. And it has 3 mechanisms of action, actually. It blocks androgen receptor binding, and it's 8 times as potent as bicalutamide. It blocks androgen receptor translocation into the nucleus, and it also blocks the androgen receptor binding with DNA, so it has 3 mechanisms of action. And it was shown first in advanced patients after chemotherapy with metastatic disease to have a 37% reduction in the risk of death. Since this agent was so active, it was now evaluated in what was called the PREVAIL trial, which we heard presented today, in patients who have metastatic castration-resistant prostate cancer. But these are patients that were primarily asymptomatic or minimally symptomatic, with a good, what we call performance status, different from the other patients in the trial post-chemotherapy. And there were more than 1,700 patients put into this trial. These are patients who are in good shape. They were randomized on a 1-to-1 basis to receive either oral enzalutamide or placebo. And in this trial, there was a interim data analysis that was to look at the radiologic progression and to also look at the overall survival. But the trial was stopped by the Independent Data Monitoring Committee when they saw that there was an extremely important difference in terms of radiologic progression-free survival. In fact, the difference was astounding. There was an 81% improvement in radiologic progression-free survival. And they also saw, not also, but importantly saw a 29% improvement in overall survival. And when you consider that this is a drug given before other therapies, many other therapies were given afterwards, particularly to the placebo arm. These are really incredible results, and they were very important, and this was late-breaking abstract number 1 in the symposium today.
All right. Heather, what are the clinical implications of that in the context of other drugs already available? What do you think?
I think we've been very lucky now in having a choice of drugs that we can use, which, as we were saying earlier, was almost unthought of 10 years ago. And I think with enzalutamide, we've seen a 17-month in the delay in the need of patients having chemotherapy, and we've seen that this is an exceptionally well tolerated drug from the point of view of the toxicities which were reported. And as Cora said, it's a tablet, it's an oral drug which men can take. So I think that this is going to be a very interesting time in that we're going to have 2 oral compounds which have shown significant benefits in the space prior to docetaxel treatment. I think it's very difficult to compare one trial to the other because with abiraterone they had prednisolone and placebo, and whereas enzalutamide it was against a straight placebo. The PREVAIL trial also had 11% of patients with visceral disease, whereas they were excluded from the abiraterone study. So I think they're different trials, and it's going to be a very difficult decision, and perhaps it's going to depend on what we're able to prescribe rather than, I think they're both good drugs, there's very little to choose between them.
All right. So we had a positive phase 3 trial reported for the first time today, but we also had a negative phase 3 trial looking at another drug, which is also an endocrine drug, CYP17 inhibitor, or Ternel, first reported today. John, can you sum up the data and give us sort of your interpretation?
Yes, well, Orternel is, it only inhibits one part of the CYP17 enzyme system in that it inhibits C1720 lyase. So technically, therefore, the side effect profile should be better than perhaps abiraterone. Now, this is a post-docetaxel trial, so there was one endpoint, primary endpoint, not 2, as we've seen in some of the other trials. So one primary endpoint and a number of secondary endpoints. The primary endpoint that was selected was the overall survival and sadly the futility boundary was passed, in other words, meaning that the trial was a negative trial. Now, when you look at the secondary endpoints and you see radiographic progression-free survival as being the number one on that list, and we do know that that actually was strongly positive. So now you've got this rather strange system whereby you have negative overall survival, positive RPFS, and then you have to say, well, it still doesn't make it a positive trial, but here we have a drug that clearly works and has an excellent side effect profile. So now you're left with a big question: why? And I thought that perhaps this was addressed today, that now you have a large number of other treatments that you can use, and you can use them much earlier than you would perhaps have done it in previous trials. And so the crossover to other treatments was considerable. This, of course, unfortunately, doesn't help the overall survival picture, as we know from other areas. So therefore, this I think tended to add to the confusion in relation to the overall survival and turn it into a negative trial. But it's an interesting drug, and we await, of course, the pre-docetaxel study, which is ongoing, and it'll be interesting to see what happens with that.
All right. So if I count well, we now have data from 5 large randomized phase 3 trials looking at new generation endocrine therapies, including abiraterone, enzalutamide, and now TAK-700. Pete, what should be next in terms of clinical research and translational research for new generation or next generation endocrine therapies?
I think the good news was clearly that there were dramatic responses seen, and some patients have very durable responses, but probably no true cures yet. It wasn't really discussed extensively in the context of these trials, but basically all of the patients, or almost all the patients that do progress, do so again with a rising PSA, which strongly suggests that this same pathway that these drugs are designed to target is reactivated or not effectively inhibited. There's a little bit of debate about that. There's some recent data suggesting that the glucocorticoid receptor, another nuclear hormone receptor, may actually be able to co-opt AR signaling. So I think traditionally we've thought the only pathway that could activate PSA was the androgen receptor, but this other data suggests that maybe other nuclear hormone receptors could do it as well. But I think the bottom line, we need to understand better these mechanisms of resistance. There are some trials ongoing now to see if higher doses of abiraterone would work. I'm not aware of any studies really looking at long-term PK and PD on patients on these drugs to see do they maintain levels. So I think there's a lot of still fundamental research that needs to be done. But the bottom line is what we've seen in many other diseases, HIV, acute myelogenous leukemia, and others, is that sequential treatments are almost guaranteed to develop resistance. And so we need to be rethinking at some level some combination therapies, providing we can deal with toxicity and cost.
The one slight anxiety that one has is that the earlier that these drugs are instituted, you have the danger that you're going to induce the bad actors. So if you deplete the cell of ligand, then the danger is that you will actually start to institute EMT, which is of course not a good thing. And then the second thing is that if you block and get rid of all the androgen receptor, well then the induction of splice variants. And so both of these are, I think, pretty potent mechanisms of resistance.
On the other, go ahead.
Yeah, that's a good point I didn't mention. So there is this emerging evidence that there are other forms of the androgen receptor that don't require ligand at all to be active. So luckily there is some basic and preclinical research now developing new therapeutics that can target the N-terminal domain, or the domain that interacts with DNA that doesn't require ligand binding. And so hopefully those will have efficacy in exactly this situation where we've pretty much exhausted therapeutics that target ligand production or ligand binding, i.e. androgens, and we really need to think about other creative ways to molecularly block that pathway.
On the other hand, there's been evidence reported recently that this next generation endocrine drugs like abiraterone can be associated with pathologic complete response in localized disease. And however, you emphasized previously the importance of combining local treatment with radiation with endocrine therapy. Do you think combining radiation with abiraterone and enzalutamide, maybe others, is really the future?
I think that's a really exciting prospect. And we know that both LHRH agonists and in fact the anti-androgen bicalutamide showed survival advantages for high risk or locally advanced disease. And I think one of the exciting ongoing trials is going to be looking at enzalutamide and indeed abiraterone in that adjuvant setting, because I think they're very promising that we could have even better results from that point of view.
Coming back to resistance to these drugs, Pete, do you think that we should integrate more cancer biopsies, specifically biopsies of metastases, in our clinical trial to try to better understand the mechanism of resistance, rather than doing only in vitro and in vivo experiments? What do you think?
Yeah, absolutely. I do want to emphasize it's still really in the discovery stage. There are some actionable targets that we would know what to do with immediately, such as if a patient has a BRCA2 mutation, those patients are clearly sensitive to PARP inhibitors, for example. But the vast majority of changes that we're starting to see from, for example, genome sequencing of metastases, we're better clarifying the landscape of mutations and alterations that occur. But so far, there aren't many yet that would be directly influencing a clinical decision. The exception might be now there are specific mutations that are apparently conferring resistance to enzalutamide and ARN509, and it doesn't look like those mutations confer resistance to bicalutamide. So you might even start thinking about some back and forth, therapies, but that's at this point in time really not yet borne out in patients. But I'm clearly a firm believer in going where the money is, i.e. in the tumor, trying to prove what actually happens in patients rather than focus only on preclinical studies. And I think we're starting to get a picture now of what an advanced prostate cancer genome looks like. And importantly, this won't be static. It's going to continue to evolve under therapeutic pressures.
All right. Another important presentation today here in San Francisco was about the radium-223 phase 3 trial and an update of this positive phase 3 trial. Cora, would you mind explaining what radium-223 is and what the data were?
Sure. Radium-223, also called alpha radium, is a alpha particle. It's a large particle. It's on the periodic chart very near to calcium, so it's a calcium mimetic, and it attaches to bone, and it has a very short emission, so you can stop the radium effects with even a piece of paper. So when you give radium 223, it's given intravenously, but there's no problem to people in the surrounding. But it attacks exactly the bone, and it attacks the tumor in the bone. It's been evaluated in what's called the ALSYMPCA trial, in which what was found was that it actually improved overall survival by approximately 30%, and it also decreased the important skeletal-related events. I don't just mean a rare new bone metastases on a bone scan, but clinically relevant skeletal-related events. And this was the ALSYMPCA trial, which led to the approval of radium-223. Today, the data are updated with longer-term follow-up from the phase 2 trial, showing no particular increase in side effects, safety over a long period of time. I believe that it was 1.5-year follow-up was given, and no new tumors were found. perhaps you can say something else about it.
Yeah. I think that one of the concerns was effects to the normal bone marrow and risks of sort of aplastic anemia, and I think that was only 1% at 1.5 years, and 3-year data is going to follow, I think, fairly soon. And there was no increase in myelodysplastic syndrome and the other sort of bone marrow toxicities that we've seen with other radiopharmaceuticals which weren't alpha emitters. So it's been really good data and good safety.
In the ALSYMPCA trial, they permitted patients who were ineligible for chemotherapy or had already had chemotherapy or didn't want chemotherapy, and there was very little myelosuppression also with this drug.
So one of the really tantalizing things about the trial is, how does it work? I mean, how can something primarily being aimed at bone metastases improve survival? Now, clearly it does. So therefore, that's something biologically that Dr. Nelson here is going to have to put on his thinking cap and try and work that one out. But there's no obvious answer. It's just one of the extraordinary things.
I agree, and it's striking to see that most of these patients who benefit don't necessarily have a drop in PSA, as opposed to what you would see if you irradiate a single bone metastasis with external beam irradiation. So I agree with you. We still need to better understand how radium-223 works.
But for sure, the dramatic decrease in skeletal-related events is important, and I think in these elderly patients, when they do have a serious skeletal-related event, such as a fracture that puts them in bed, these are one of the things that definitely decreases their survival. So without a biologic explanation and a simplistic explanation, this drug also works by decreasing the skeletal-related events, and I think that's an important part of it.
Right. So many people are asking the question, okay, we've got, let's say, 6 new treatments in the last 5 years or so, 10 years or so, that improve overall survival in castrate-resistant disease. So how are you going to be using these drugs now, tomorrow? Let's say they're all available. And that's obviously a very important and difficult question to address. Who'd like to take this one?
Well, I can start. One of the problems we're using them where they're how they've been licensed and how they're available. So, working in a public health system, I can only use the drugs that are available.
Sure.
In the United States, where you can give drugs in any order you want, perhaps, I think it's much more of a problem to decide. What we do know is that looking at retrospective data from small series, particularly from those patients treated after chemotherapy in the AFFIRM trial and in the abiraterone trial, that it seems that if you give enzalutamide first, the abiraterone doesn't work as well, and if you give abiraterone first, perhaps the enzalutamide doesn't work as well. Also, there's some cross-resistance also with docetaxel, because they're all working on the AR receptor, and I think we really need to think and do smart trials in order to understand what is really the best sequence in which to give these drugs, or perhaps which combination to give these drugs. For instance, if abiraterone lowers testosterone and increases androgen receptor expression, and enzalutamide lowers androgen receptor expression and increases testosterone, combining the two makes sense. And there are trials such as the Alliance trial in the United States, and there's a similar European trial looking at the combination of those drugs. Those drugs also could easily be combined with some of the newer immunotherapies that are less toxic, which may be really of interest as well.
John, what do you think? Is the future mostly sequence, combination, or maybe personalized medicine?
Oh, right. No, that's a big one. Or maybe we should be calling it precision medicine,
yes,
which is.
I think we should.
So I think yeah. I mean, I think precision medicine is definitely the way that we will go. The recent studies have shown, Peter's been involved in a number of them, and others, that there is definitely a huge disturbance of the genome in prostate cancer, and that this is much more extensive than I think we felt it had been. There are now new genes coming up that we didn't realize were involved, but actually have a link with this. For example, SPOP, which in people who have a deletion of SPOP gene, they have a they also have an absence of the TMPRSS2 ERG fusion. So it's a very interesting area. So that, I think, is definitely going to become the one. If we talk about the reality that we have at the moment, I think that people are going to have to work out the question of combination. I think that probably is the most interesting one. I think the sequencing in the absence of combination of drugs, I think, is also very, very important, and some way to lower the cost.
Right. Heather.
I completely agree, and I agree with Cora that we actually need good clinical trials. There's lots of retrospective series coming out, and it's quite difficult to interpret those really because they're small numbers and they're not giving us a definitive answer. And I think the worry is that people are going to jump on one little series or another and take that as being, you know, level 1 evidence, which it really isn't. So we need proper sequencing studies. Until we have those, and assuming sort of good efficacy with all these drugs, then I think you're probably going to use the ones with the least toxicity and the best quality of life for the patient first, and give them the longest time on the drug that isn't going to impact on their daily life. Okay,
makes sense. Pete?
No, I agree with that entirely. I think absent really having molecularly defined markers that would indicate a clear resistance or response, it will be guided by keeping patients as functional as possible with the least side effect burden. So I think the sequence is going to be fairly logical, with the exception of if enzalutamide is approved prior to chemo, which it most likely will be, how will you choose between abiraterone and enzalutamide? And there it may be a cost issue in some places, there it might be a prednisone issue if there's comorbidities, etc. But I think both of those drugs would likely be used before chemo, then it'll be docetaxel, and then, so I think there's a fairly logical sequence of events. Gets much more complicated if you're going to be trying to combine things.
That sounds very, very wise. So I think I would like now to thank you all and thank eCancer for giving us the opportunity to have this great discussion. Thank you very much.
Thank you.
Okay, cut.